Okay, let's unpack this. We're diving into a topic that sits right at the intersection of, well, complex engineering, meticulous patient physiology, and absolute safety.
It really does.
We're talking about the apparatus and protocols that sustain life during anesthesia. This deep dive is really custom tailored for you, the learner, who's focused on mastering the machinery and protocols for the MD anesthesiology exams.
Right. And this is where equipment knowledge, and I think more importantly, understanding the failure modes, is absolutely paramount.
It's everything.
And what's fascinating here is how the exam focus has, it's evolved.
Yeah.
Historically, those big 20-mark questions might have just been about the components of a classic Boyles machine.
Right, like name the parts.
Exactly. The nuts and bolts of flow meters, pressure regulators, the pin index system, and so on.
Right.
But our analysis today, based on the really high-yield material we have, it shows we need to pivot.
A necessary pivot.
Yeah.
So where does that leave us?
We need to concentrate heavily on the layers of modern safety systems, the cutting-edge volatile delivery mechanisms, critical airway adjuncts, and monitoring protocols. Because really, these are the components that govern safe clinical practice today.
And they're the things that are perpetually tested for their clinical application.
Precisely. And your understanding of where they might fail is key.
Exactly. And this shift, it demands we start with the philosophical origin of safety in our field. I mean, anesthesia delivery fundamentally relies on equipment that accurately controls gas flow and agent concentration.
It does.
So we have to frame the evolution of the apparatus not just as a straight line of technological progress, but really as a series of safety responses.
That's absolutely right. The historical context is so crucial for understanding our current systems. A monumental safety landmark, for instance, was the recognition that simply mixing nitrous oxide and air, well, it formed a dangerously hypoxic mixture.
So this wasn't just a physiological observation, it was a design flaw in the early delivery systems.
It was a fundamental design flaw. And Sir Frederick Hewitt, a hugely influential early British practitioner, he responded by designing the first anesthetic apparatus that was specifically engineered to deliver oxygen and nitrous oxide in variable proportions.
So that was the foundational moment, the first real step in engineering hypoxia prevention directly into the machine itself.
It was. And Hewitt's contribution to patient safety, it wasn't just limited to gas flow. We also have to note his development of a key airway appliance, his 1908 Airway Restorer.
Ah.
This device introduced the fundamental, now universally accepted practice of inserting an oral device to help maintain ventilation and overcome that upper airway obstruction during an anesthetic.
So it's this dual approach, controlling the gas and securing the airway. That really sets the stage perfectly for the modern concept of the anesthesia workstation.
Exactly. And that leads us directly to the exam relevance. These foundational concepts are frequently bundled into those long-form 20-mark questions.
How might they frame that?
Well, they might frame it around a clinical scenario. Something like, a patient becomes hypoxic. Enumerate the layers of safety features inherent in the machine in your protocol that should have prevented this.
I see.
Or they'll demand the precise, stepwise, pre-use checks. And those checks now, they extend far beyond just checking pressure gauges. They include confirming the readiness of sophisticated volatile delivery systems and ensuring complex ventilation strategies are all set up and ready to go.
So mastering this material is really mastering operational safety.
That's the bottom line.
So let's transition from that historical response to hypoxia and obstruction to the modern practical flow. Let's focus on the schematic of gas and device movement, from the source all the way to the patient. Where do we begin?
Well, we have to start with maintaining the patient's breathing pathway itself.
Makes sense. The basics first.
We have to begin with the most frequently used oropharyngeal airway, the simple but essential Goodell airway. Despite all the technological advancements we have, this device, it remains the cornerstone of basic airway management.
And for the exam, you need to know it inside and out.
You need to know its construction details cold. It's typically made of rubber or a firm plastic, and it's available in precise sizes from 0 for an infant all the way up to 6 for a large adult. And it features that distinct, large flange at the mouth end.
And what about the features that are designed for safety and function? I'm thinking of the bite block, for instance.
Crucially, yes, it has a reinforced bite portion. This isn't just for protection. It ensures the patient doesn't occlude the tube by biting down.
Which protects the patient's teeth, but also keeps the airway patent.
Exactly. It maintains the tube's patency. Its gentle curve is anatomically designed to follow the contour of the tongue, and it physically displaces it forward, off the posterior pharyngeal wall.
Which is the most common site of obstruction in an unconscious patient.
It is. The tongue just falls back, and then there's this functional channel.
What's the purpose of that?
Well, it has a tubular channel throughout its length, and this is a dual-purpose channel. It facilitates air exchange around and through the tube, and it allows for immediate suctioning of pharyngeal secretions without having to remove the airway adjunct itself.
And correct placement is key.
It's everything. You insert it upside down with the concavity facing the tongue to navigate past the palate. Then you rotate it 180 degrees as it approaches the posterior pharynx.
How do you confirm it's seated correctly?
It's correct when that flattened, reinforced section rests comfortably between the patient's teeth or their alveolar margins. And, if it's repeatedly rejected or causes gagging, it's likely too long or the patient is just too light.
And if it keeps popping out?
Then it needs to be replaced with a smaller size. Simple as that.
Okay, so moving from that essential manual adjunct to the really complex hardware, let's look at modern gas delivery. Specifically, the volatile agents that have challenged the very design principles of the anesthesia machine. We have to discuss desflurane.
Desflurane is a perfect exam case study in applied physics. Its properties, specifically its high volatility, with a boiling point near room temperature around 23 degrees Celsius.
And its relatively low potency.
Right, it requires about 5 times the concentration of isoflurane. Those two properties make it impossible to deliver reliably using a conventional variable bypass vaporizer.
What would happen if you tried?
Well, if you tried to use a standard vaporizer, the rapid cooling that's caused by the vaporization process, the latent heat of vaporization, it would quickly drop the temperature below 23 degrees, and the delivery concentration would just plummet uncontrollably.
That physical constraint is what necessitates the completely redesigned Tech 6 Plus vaporizer. This is where the whole schematic flow concept fundamentally changes. So how does this high-tech, pressure-controlled injection system work?
Well, it's an electrically driven, thermostatically controlled device. It addresses the physical problem by isolating the desflurane liquid in an electrically heated reservoir, or sump.
And that's kept at a very specific temperature.
A very consistent 39 degrees Celsius. This temperature is significantly above desflurane's boiling point, which forces the liquid into a vapor phase and creates a high, stable internal pressure, precisely 2 atmospheres, or about 1,500 millimeters of mercury.
So it's essentially a pressurized, pure vapor factory.
Exactly. The concentration is then determined electronically. The control dial setting is converted into an electronic signal, which dictates the required flow rate of pure desflurane vapor.
And where does that vapor go?
This pressurized vapor is then injected directly into the main fresh gas mixture, downstream of the oxygen and nitrous oxide flow meters and before the common gas outlet.
Okay, so this is the critical schematic difference.
It is. The fresh gas mixture does not flow through the sump. This prevents the temperature fluctuations that are inherent in those variable bypass designs. It's an engineered solution to maintain concentration stability, regardless of the ambient temperature or the fresh gas flow rate.
That makes the schematic visualization of the gas pathway fundamentally different. It moves from a flow-through system to a precise electronic injection system.
Exactly.
Moving into the detailed components now, we have to touch upon the physics that governs gas delivery, especially within the narrower confines of the breathing circuit and the patient's tubes.
We do. We need to remember the fundamentals of flow behavior, which are characterized by the Reynolds number, or Re.
Okay, but instead of letting this feel like a random physics lecture, let's tie it directly to our airway equipment. Let's talk about the tracheal tube.
Perfect. Flow behavior dictates resistance, which directly impacts the work of breathing and the ventilator's performance. We know that flow is laminar if the Reynolds number, which is a ratio involving velocity, density, tube diameter, and viscosity, is low, specifically between 0 and 2000.
And laminar flow is smooth.
It's smooth, and resistance follows Poiseuille's law. What that means is resistance is inversely proportional to the 4th power of the radius. This is why a very small decrease in the tube's radius causes a massive increase in resistance.
A huge increase. And turbulent flow.
If the Reynolds number exceeds 4,000, the flow becomes turbulent. It's messy, disorganized. Resistance then becomes proportional to the square of the flow rate, and it changes less dramatically with radius changes.
So where do we operate clinically?
In clinical systems, we operate largely in the transitional zone, between 2,000 and 4,000. But why this matters for the tracheal tube is crucial. even if the flow is relatively laminar, any nonlinear construction.
Like bending a tube or kinking it.
Exactly. Or even having sharp edges on connectors. It significantly increases the pressure drop that's required to maintain a unit of flow. This is a crucial consideration when you're deciding on tracheal tube placement and connections, especially in pediatric or compromised adult airways where resistance is already high.
That reinforces the point that every connection, every angle, every diameter choice has a profound physical consequence.
It does.
Let's return to the volatile delivery system, focusing again on the desflurane vaporizer, the Tech6+. But let's shift the focus to the clinical application and the high-yield Viva trap of altitude.
A classic Ziva question. So we've established the construction. Electrical heating to 39 degrees Celsius to achieve 2 atmospheres of pressure. While this system brilliantly solves the volatility issue, the clinical relevance concerning elevation is where many trainees stumble.
Okay, so the Tech6+ maintains a constant concentration of the agent, regardless of changes in ambient barometric pressure, which sounds great. But the therapeutic effect is driven by the partial pressure of the agent reaching the brain.
Precisely. As you increase elevation, the ambient pressure decreases. Since the total concentration remains constant, let's say 6% desflurane, the absolute partial pressure exerted by that 6% mixture also decreases.
So the concentration dial remains constant, which gives you this illusion of consistent delivery. But the effective dose reaching the patient's central nervous system is actually lower because of the drop in barometric pressure.
That's it exactly. Therefore, if you are operating at altitude, say in a hospital in the Himalayas, you must manually increase the desflurane concentration on the control dial to achieve the same target therapeutic partial pressure.
And this is a non-negotiable adjustment.
Absolutely. And it's an important distinction from the older variable bypass vaporizers, which typically achieve a kind of passive automatic compensation because the vaporizing chamber is directly exposed to the ambient pressure changes.
So failing to manually adjust the Tech6+ at high elevations can lead to what?
Inadequate anesthetic depth, patient movement, and a major safety incident. It's a critical point to remember.
Moving beyond the hardware, let's look at the airway components and breathing system mechanics that work in concert with the machine. We have this hierarchy of airway maintenance.
We do. And tracheal intubation remains the gold standard. It establishes the definitive airway. By placing a cuffed tube past the vocal cords, it provides the maximal protection against aspiration of gastric contents.
And allows for total control of ventilation.
Total control of positive pressure ventilation and gas exchange.
But what's been the major development that has really changed routine practice?
That would have to be supraglottic airways, or SGAs. These devices, which sit above the larynx, like the LMA family of devices, are rightly described as one of the most important developments in airway management over the last 40 years.
Why so revolutionary?
They're fast to insert, they provide a good seal for ventilation in most cases, and they have truly revolutionized routine, non-high-risk airway management.
Okay, now let's get into the mechanics of the machine's output, the ventilation components. The choice between volume control and pressure control is a core part of the pre-use strategy.
And operationally, the two modes are fundamentally different and they carry different risk profiles. In volume control ventilation, or VCV, the clinician sets a predetermined tidal volume.
Say 500 milliliters.
Right. The ventilator then delivers the flow necessary to achieve that volume, but the resultant airway pressure required to deliver it is entirely variable. It depends completely on the patient's lung compliance and resistance.
So that pressure could spike dangerously if the patient starts bucking or if their compliance drops suddenly.
It could. In contrast, pressure control ventilation, or PCV, prioritizes pressure stability.
So how does that work?
In pressure control, the clinician sets a predetermined, safe maximum inspiratory pressure, let's say 20 centimeters of water. The delivered volume, however, is highly variable. It depends entirely on the instantaneous compliance of the patient's lung and chest wall.
And the ventilator ignores this volume variability.
It does. This is a critical distinction that demands constant attention from the clinician, especially in long cases where compliance can change quickly.
And although our sources only briefly mention the scavenging system, its function is so intimately linked to occupational safety and the use of volatile agents like desflurane.
Absolutely. Scavenging is not just an adjunct. It's an essential safety feature required by regulation. Its goal is the containment and removal of waste anesthetic gases, so volatile agents and nitrous oxide from the operating room environment.
Which is crucial for minimizing occupational exposure to staff.
And, increasingly, reducing the environmental footprint of potent greenhouse gases like desflurane. Its proper function has to be checked right alongside the machine itself. It's part of the full check.
We now enter what is probably the most critical area for clinical safety and exam success, safety systems. This section really details the multiple layers of defense engineered into both the equipment and the protocol to prevent the most common catastrophic failures.
Right, things like hypoxia and aspiration.
Here's where it gets really interesting, because these are the systems that save lives when human error inevitably occurs. Where do we start?
We have to start with the historical baseline hypoxia prevention. The foundational safety mechanism, as we've noted, prevents the delivery of dangerously low oxygen concentrations.
Go back to Hewitt's apparatus.
Exactly. The historical source reminds us that this started with Hewitt's apparatus, designed to deliver oxygen and nitrous oxide in variable proportions, moving away from those dangerous N2O air mixtures.
The failure implication is pretty straightforward there.
Extremely. Delivery before this mechanism existed resulted in patient hypoxia and, sadly, anesthetic death.
Okay, moving to modern patient-side monitoring. Pulse oximetry, it's non-negotiable, and its job is to prevent undetected hypoxemia. We need the principles, but the exam focus has to be on the limitations.
Absolutely. Pulse oximetry provides continuous estimations of SO2 by measuring the differential absorption of two wavelengths of light, typically red and infrared, by oxygenated versus deoxygenated hemoglobin. The critical concept is that this works well in the steep part of the oxygen dissociation curve.
But its ability to estimate SO2 becomes mathematically limited when SpO2 is less than 97%.
That's the key.
So let's nail down these limitations, as these are perennial Viva questions. What's a clinical implication of the curve shape below 97%?
Well, the oximeter's worst performance is in that critical saturation range of 76 to 90%. Studies show that in this range, the device tends to read approximately 5% higher than the actual measured arterial saturation.
And the confidence intervals are wide.
Very wide. This means a reading of 85% could easily be 80% or even lower, demanding immediate intervention. If the reading is low, it's not just concerning, it's unreliable, and it may be understating the severity of the hypoxemia.
Beyond poor saturation, what other technical factors can compromise the reading?
First, decreased perfusion. Pulse oximetry relies on pulsatile flow. So if the patient is hypotensive, vasoconstricted, or the monitoring site is just poorly perfused.
Like in shock or if it's under pressure.
Right. The signal quality degrades, and the readings become unreliable or they disappear entirely. Second, abnormal hemoglobins are a major technical flaw. Methemoglobin and carboxyhemoglobin absorb light at the wavelengths used by the oximeter, and that leads to erroneous, often misleadingly normal readings, even when the patient is profoundly hypoxic.
So, for example, CO poisoning can give you a falsely high SpO2.
It often does. And finally, there are subtle but documented reports that confirm skin color can alter accuracy, particularly at lower saturations, which adds another layer of uncertainty.
The next safety checkpoint is the confirmation of gas delivery and tube placement via end-tidal CO2 monitoring, or ETCO2.
ETCO2 is the primary method for confirming successful and proper positioning of the tracheostomy tube. While confirmation requires clinical signs like chest rise and breath sounds and maybe fiber optic bronchoscopy, ETCO2 is immediate and it's continuous.
So what's the definitive sign of successful placement?
The sustained presence of a normal capnograph waveform reflecting CO2 excretion. The loss of that ETCO2 signal, or a sudden change in its shape, is an immediate red flag.
And that could indicate what?
Incorrect tube position, like esophageal or mainstem bronchial intubation, a disconnection of the breathing circuit, or of course, cardiac arrest.
We also have to address the safety net against paralysis residual neuromuscular blockade, or RMB.
RMB is a major cause of postoperative respiratory events. We rely on neuromuscular monitoring, specifically the train of 4, or TOF count. This applies 4 supramaximal electrical stimuli to a peripheral nerve. The TOF count reliably assesses the onset and a moderate level of blockade.
But for recovery, we use the TOF ratio.
Yes, comparing the height of the fourth twitch, T4, to the first twitch, T1.
The core safety failure here seems to be the reliance on subjective assessment. How does objective monitoring close that safety gap?
Well, subjective visual or tactile estimation of fade is accurate only if the TOF ratio is less than 0.4, which means the patient is still quite deeply blocked. The critical danger zone is the range between a TOF ratio of 0.4 and 0.9.
And in that zone?
In this zone, fade cannot be reliably detected by the human eye or touch, yet the patient's pharyngeal and laryngeal muscles are still significantly weakened.
Which leads to an increased risk of aspiration and upper airway obstruction upon extubation.
Absolutely. Therefore, objective monitoring is absolutely necessary to exclude clinically significant residual paralysis.
So if the resident says, I saw 4 twitches, without objective data, they are taking an unacceptable risk if that ratio is below 0.9.
A huge risk. And there are other limitations to the TO system. It's primarily designed to monitor non-depolarizing blockade and recovery. It doesn't allow the clinician to quantify intense or deep levels of block where there are no responses at all.
A count of 0.
A count of 0. Furthermore, it doesn't reliably monitor the depolarizing phase-I block caused by succinylcholine, which characteristically presents with no fade.
Meaning the TOF ratio stays at 1.0.
It does, unlike the non-depolarizing block, which shows a ratio of less than 1.0.
Finally, the safety system governing the end of the anesthetic extubation. This is often the most dangerous 5 minutes of the entire case.
It really is. Extubation is a component of airway management with a high potential for significant complications: laryngospasm, aspiration, reintubation. Safety mandates that an extubation plan be formulated preemptively.
So it's not just a decision, it's a full strategy.
It's a full strategy that includes the decision deep versus awake,
Yeah.
the management of the residual blockade, and critically, a specific rehearsed strategy for reintubation should the patient fail after the tube is removed.
And that deep versus awake decision.
It has to be a high-stakes, conscious risk-benefit assessment based on the patient's condition, the surgical site, and the perceived difficulty of reintubation.
Okay, moving beyond the hardware checks, let's detail the operational safety protocol. Section 5, anesthesia machine checks and pre-use protocols. This is a perennial exam favorite, isn't it?
Oh, absolutely. It's often presented as a practical viva or a long-form written question detailing all the necessary steps. The rationale here is all about preparation, mirroring that historical dedication to safety we talked about.
We have to anticipate potential difficulties and prepare an effective response.
That's it. And the checkout protocol should be structured around the complex airway and ventilation management the patient will undergo, not just the machine's physical components.
So let's break down the necessary preparation into 5 crucial steps that extend beyond just the apparatus. Step 1, airway assessment and preparation.
This is foundational. It involves a complete, meticulous evaluation of the airway Malapati score, neck mobility, thyromental distance, mouth opening, and a thorough knowledge of difficult airway predictors.
It's more than just passive assessment.
Much more. The anesthesiologist must formulate a mental difficulty score and identify potential alternative strategies before induction. This means ensuring the necessary alternative equipment, an LMA, a fiber optic scope, a cricothyrotomy kit, is physically present and functional in the room.
Step 2, the airway management plan. Assessment is followed by a concrete plan.
Yes, and we must utilize established guidelines like the ASA difficult airway algorithm, which standardizes responses to both anticipated and unanticipated difficulty.
And what about cognitive aids?
Cognitive aids like the Vortex approach or ASE infographics are not substitutes for knowledge, but they are mandatory tools for guiding rapid clinical decision-making during an emergency. The plan has to cover Plan A, routine intubation, Plan B, an SGA, Plan C, rescue ventilation, and Plan D, a surgical airway.
So you're ready for anything.
You have to be.
Step 3, checking the ventilation strategy. This means deciding between VCV or PCV and ensuring the machine is ready for the chosen mode.
This choice is patient-specific. Pressure-controlled ventilation, or PCV, is generally safer in scenarios with an increased risk of barotrauma or lung injury,
Such as?
post-lung transplantation, ARDS, or during a pneumonectomy. This is because it guarantees that a peak airway pressure threshold is never exceeded.
But I've heard faculty criticize PCV for making trainees complacent about volume. How do you mitigate that risk during the pre-use check?
That is a critical probing point for exams. While PCV avoids sudden pressure spikes, the delivered tidal volume is highly variable. Compliance can change rapidly due to patient position, surgical retraction, or lung disease progression.
Meaning the delivered volume could drop dangerously low without generating an alarm.
Exactly, leading to undetected hypercarbia or hypoventilation. Therefore, the preparation check for PCV involves setting appropriate alarms and a commitment to closely monitoring the expiratory tidal volume throughout the case, ensuring it meets physiological requirements.
Okay, step 4. Preparing the lung protective strategy, which centers on managing atelectasis, a universal consequence of general anesthesia.
This is a very high-yield concept linked to improved outcomes. The preparation involves ensuring the ability to perform recruitment maneuvers. These are performed to expand collapsed lung tissue, or atelectasis, which can occupy up to 30% of the lung field after intubation.
And what are the specifics of that maneuver?
The standard protocol involves applying a sustained high-pressure 40 centimeters of water or greater for 8 to 10 seconds immediately after intubation. This pressure is designed to overcome the critical opening pressure of those collapsed alveoli.
So the check is to make sure the ventilator can actually do that safely.
Right, and that the necessary monitoring is in place.
And what are the risks we must check for during the maneuver itself?
We must monitor the immediate physiological consequences. The high intrathoracic pressure transiently inhibits cardiac output by reducing venous return, which can cause significant bradycardia and hypotension.
So preparation includes having vasopressors ready and warning the surgeon.
Absolutely. Efficacy is then checked by measuring PO2 improvement and improvement in lung compliance after the maneuver is complete.
Finally, step 5, the comprehensive monitoring check.
This step confirms that the patient-side devices are functional, calibrated, and their known limitations are internalized. Specifically, confirming pulse oximetry function means confirming you understand its inherent inaccuracies.
Knowing when to doubt the number.
Exactly. When to doubt it due to poor perfusion, low saturation, or the presence of abnormal hemoglobins. It's an intellectual check as much as it is a physical one.
This systematic approach helps prevent the common pitfalls that challenge trainees. So what are the common mistakes examiners love to probe, the ones that show a failure in this preparatory mindset?
The most dangerous mistakes always stem from a lack of anticipation. Failing to anticipate the difficult airway, or, critically, not having a formulated reintubation plan ready after extubation, that is often tested in vignettes. Another major failing is the over-reliance on subjective assessment of neuromuscular function. Trusting your hand to detect fade when the TOF ratio is exactly in that 0.4 to 0.9 danger zone, resulting in undetected residual paralysis.
And the Deslorraine trap.
And, of course, the Tex 6+ altitude trap. Failing to manually increase the Deslorraine concentration when operating at decreased ambient pressure, leading to inadequate depth of anesthesia. These show a failure to link physical principles to clinical action.
Since success in the exam often relies on the ability to generate a clear, comprehensive answer quickly, let's discuss how to visualize these high-yield concepts using diagrams that lend themselves well to quick recall and maximum marks.
Excellent point. Diagrams are absolutely essential for conveying complex relationships efficiently, and we should focus on the conceptual visuals defined by our sources.
Okay, first, the conceptual diagram illustrating the mechanics of protective ventilation, which is often relevant for ARDS or high-risk lung patients.
You should draw a pressure volume, or PV curve. You want to contrast a normal lung curve with a highly non-compliant lung, like an ARDS. The ARDS curve visually demonstrates two critical zones.
Which are?
First, the high opening pressure, or P1, that's required just to get the lung to move at all. This highlights the need for a sustained recruitment maneuver. Second, the curve then flattens out, showing that only a small further increase in lung volume, or P2, quickly results in a massive pressure spike.
Which indicates the risk of barotrauma and volutrauma.
Precisely. The diagram should label the desired plateau pressure as the ideal low-volume tidal ventilation range. This communicates the principles of low tidal volume and PEEP all in one visual.
That immediately translates the concepts of volutrauma and atelectotrauma into a single, powerful image. Okay, next, the volatile delivery system, the Tex 6+ mechanism.
The diagram here has to differentiate this system from all others. You draw a simplified gas flow pathway. The crucial components to label are the main fresh gas flow path, the O2N2O mixture, and separate from this, the electrically heated reservoir or sump.
And you have to label the sump with its specific parameters.
Yes, 39 degrees Celsius and 2 atmospheres of pressure. You have to show that the pure pressurized vapor is then metered and injected into the fresh gas stream immediately before the common gas outlet. This schematic visually proves that the system worked by electronic injection, not by a flow-through variable bypass.
And finally, the cornerstone of neuromuscular recovery, the TOF principle. How should you draw that?
This is a classic visualization. You draw a horizontal axis representing time, with 4 equally spaced vertical lines representing the electrical stimuli, T1, T2, T3, T4. The height of the subsequent peaks represents the muscle response.
And you must illustrate the key difference.
Yes. For a non-depolarizing block in recovery, the peaks will show fade. T4 will be notably smaller than T1, meaning the TOF ratio is less than 1.0. In contrast, the diagram should show a second set of equal peaks for a depolarizing phase I block, where no fade occurs. The TOF ratio is 1.0. This simple comparison is incredibly high impact for explaining the physiology of fade.
This technical knowledge is useless without application. Let's ground this in Section 7, clinical correlation and pitfalls. We need to cover real-life scenarios and the clinical application questions examiners love to probe. We've established that monitoring is crucial, but let's explore its physiological flaws in specific scenarios.
A prime example is the use of ETCO2 during one-lung ventilation, or OLV, which is typical for thoracic surgery. In a normal patient, ETCO2 is a reliable, non-invasive proxy for arterial CO2, with a gradient of only 2 to 5 millimeters of mercury.
But during OLV?
During OLV, we are ventilating only one lung, which is now receiving all the cardiac output. The resulting physiological shunt and VQ mismatch causes the individual PET CO2 gradient to become significantly larger and highly variable.
Why does that gradient widen so dramatically?
Because the ventilated lung becomes hyperperfused relative to its ventilation capacity. This leads to increased physiological dead space and inefficient CO2 elimination. The ETCO2 reading, therefore, becomes a much less reliable monitor of the true PET2.
Which forces the clinician to rely more heavily on intermittent arterial blood gas analysis.
Exactly. You have to understand that the non-invasive monitor is compromised by the fundamental physiological changes induced by the procedure.
Shifting to an equipment mishap, let's discuss the catastrophic potential of airway devices, specifically double lumen tubes or DLTs.
Airway trauma or rupture of the membranous trachea or bronchus is a rare but life-threatening complication associated with DLT insertion. This occurs due to mechanical stress.
How so?
Either an oversized DLT is forced through the vocal cords or into the bronchus, or an undersized DLT migrates too distally, causing the rigid portion to lacerate the airway wall, often at the junction of the tracheal cartilage and the membranous posterior wall.
And what must the clinician recognize immediately in that scenario?
The signs include unexpected or massive air leaks, which prevent lung isolation, subcutaneous emphysema developing rapidly, acute airway bleeding into the lumen of the DLT, or occasionally the thoracic surgeon actually visualizing the cuff protruding into the surgical field.
And failure to recognize that is a disaster.
It can lead to tension pneumothorax or massive hemorrhage if you don't intervene, usually with bronchoscopic confirmation and immediate surgical repair or conversion to a single lumen tube placed proximal to the injury.
This really highlights how algorithms serve as safety systems.
Precisely. Airway algorithms, the ASA, the vortex approach, they provide guidelines not just for intubation, but for managing the consequences of failure. They mandate that the response to total airway failure be systematic and rapid, thus preventing total hypoxia and death.
And lung protective ventilation is a safety system in itself.
It is. Low tidal volume, proper PEEP. It prevents mechanical injury, volutrauma, and atelectotrauma, which fundamentally improves patient outcomes in critical lung pathology.
Let's pivot to the pharmacological follow-up questions examiners love, which link equipment or a procedure to drug action. Let's start with succinylcholine and burns.
This is a classic. Succinylcholine, a depolarizing muscle relaxant, must be avoided in patients 48 to 72 hours post-burn injury due to the risk of an exaggerated, potentially fatal hyperkalemic response, which can induce cardiac arrest. The 48 to 72-hour window is critical. Immediate post-burn administration is usually safe.
And what is the underlying mechanism the examiners are looking for?
The burn injury and other conditions like major trauma or denervation causes a proliferation and increase in the number of extrajunctional acetylcholine receptors across the muscle membrane, moving beyond the usual motor end plate.
So when acetylcholine is administered?
These vast numbers of receptors depolarize simultaneously, releasing an exaggerated, often massive amount of potassium into the bloodstream. Examiners will also probe your knowledge that during this period, patients also develop a decreased sensitivity or resistance to non-depolarizing muscle relaxants.
A change that can persist for over a year.
It can.
Okay, next, back to monitoring limitations. If your SpO2 reads 85% on a patient who looks relatively pink, what are the non-physiological technical reasons for that inaccuracy that you must consider?
You need to immediately cycle through the limitations. Is the perfusion poor? Low blood pressure? Cold extremity? Are there abnormal hemoglobins present? A suspicion of CO poisoning or methemoglobinemia?
Or external factors.
Right. Is there strong ambient light, or does dark skin color reduce accuracy in that critical low saturation zone? This shows you understand the technology, not just the number.
Finally, anatomy relevant to airway equipment insertion.
Examiners frequently ask about common sites of obstruction, reminding you that equipment selection relies on anatomy. The vilipharynx, the region where the nasopharynx ends at the soft palate, is a common site of obstruction in both the anesthetized and the unconscious patient.
So understanding that 3D anatomy is key.
Understanding the precise three-dimensional anatomy of the oropharynx and hypopharynx is essential for correctly placing airways, LMA cuffs, and intubation tubes without causing trauma or field seating.
We've covered immense ground dissecting the integrated safety workstation that defines modern anesthesia practice. Now for the final review. Let's focus on the 10 most crucial exam essential take-home points.
Okay, here is the crisp recap of the highest yield exam-ready facts we've discussed today.
Number 1.
1. The Disflurane vaporizer, the Tech 6 Plus, is an electronic injector using electrical heating to 39 degrees Celsius, creating 2 atmospheres of pressure, and critically requires manual concentration compensation when operating at altitude.
Right, due to that decreased partial pressure. Okay, number 2.
2. Historical anesthesia safety began with Sir Frederick Hewitt, who engineered the first apparatus to deliver oxygen and N2O in variable proportions after recognizing the hypoxic risk of the N2O air mixture.
Number 3.
3. The Guedel airway, sizes 0 to 6, is the most frequently used oropharyngeal airway. It works by physically displacing the tongue forward and has a tubular channel for air exchange and suction.
4.
4. Tracheal intubation provides the maximal protection against aspiration. It's the definitive airway. While supraglottic airways, or SGAs, are recognized as a major development for routine, non-high-risk airway management.
Number 5.
5. In mechanical ventilation, volume control sets volume, while pressure control sets pressure. When using PCV, the delivered volume is variable and requires close, continuous monitoring due to rapid changes in lung compliance.
Halfway there. Number 6.
6. Recruitment maneuvers using sustained pressure of 40 centimeters of water or greater for 8 to 10 seconds are performed post-intubation to expand atelectasis, requiring careful monitoring for adverse effects like bradycardia and hypotension.
7.
7. Pulse oximetry accuracy is notably poorest between 76 and 90% SpO2 and is severely compromised by decreased perfusion and the presence of abnormal hemoglobins like methemoglobin or carboxyhemoglobin.
Number 8, a really critical one.
8. Objective monitoring of the TO ratio is mandatory to detect residual neuromuscular block when the ratio is between 0.4 and 0.9, which is the range where subjective visual or tactile assessment consistently fails.
9.
9. Extubation is a high-risk process demanding a preemptively formulated plan that must include a clear, specific strategy and readily available equipment for reintubation if post-tube airway failure occurs.
And finally, number 10.
10. Critical thinking tools, such as the ASA difficult airway algorithm and cognitive aids, are mandatory clinical tools for guiding rapid decision-making during difficult airway emergencies to prevent hypoxia.
That is a phenomenal synthesis of safety and engineering principles. So to wrap this up in the style of a concise, high-scoring exam conclusion,
The modern anesthesia machine is no longer a simple Boyles apparatus, but rather a complex integrated workstation where patient safety is meticulously engineered through redundancy and rigorous protocols. Key to safe practice are robust delivery systems, such as the electronically precise Disflurane Tech 6 Plus, comprehensive patient monitoring, particularly a pulse oximetry with a clear understanding of its limitations, and objective neuromuscular assessment, and unwavering adherence to established protocols. Mastery requires not only recall of the components, but also an understanding of their failure modes, and the ability to apply systematic thinking, whether choosing VCV versus PCV, executing a recruitment maneuver, or formulating a difficult extubation plan. This comprehensive approach constitutes the essential knowledge base required of the modern MD anesthesiologist.
Excellent. This dive has emphasized how the fundamentals of physics and meticulous preparation really override any single piece of equipment. So what does this all mean for your application of this knowledge in the real world? This raises an important question.
It does.
Given the constraints of flow physics, specifically that dramatic resistance increase in laminar flow proportional to the inverse fourth power of the radius, how does that principle justify your immediate choice of the largest appropriate tracheal tube size in a critical emergency airway scenario? And how would that calculation change if you suspected a kink, forcing the flow into a transitional or turbulent state?
That pushes the knowledge beyond simple recall. You must be able to justify your clinical choices, like minimizing resistance to reduce the work of breathing using fluid dynamics principles. Use these physical engineering concepts to justify your answers in your clinical practice and your examination vivas. Good luck with your revision and your eventual practice.
We'll catch you on the next deep dive.